Welcome all. We continue with our oncology series, and today's session is about CA endometrium. So today we will discuss about the CA endometrium. The initial part we are going to discuss up to the staging, and this session is based on mainly two reports. That is the FIGO Cancer Report 2021, that is cancer of the corpus uteri 21 update, and then there is a recent update of FIGO 2023, that is the staging of endometrial cancer. Okay, so this staging I have also incorporated into this session. Okay, so here in this session we'll cover about the introduction, anatomy, histopathology, grading and staging. The concepts are very important. There can be either short note or that it may be a part of full question. At least in the vivas, these concepts you should talk. Okay, so coming to the terminology as such, the cancer of corpus uteri. Okay, so when we say about the corpus uteri, that means we are talking about the uterus. Okay, so the corpus uteri will correspond to the upper two-thirds of the uterus, which is situated above the level of the internal os. Okay, the portion which lies above the line joining the tubo-ovarian orifices is called as fundus. Okay, so above the tubo-ovarian orifice you have the fundus. So most cancers of the corpus uteri arise from epithelial lining of the uterine cavity, that is the endometrium. Okay, so most of the cancers will arise from the endometrium. When we talk about the uterus, uterus will have endometrium, uterus will have myometrium. Okay, but when we are talking about the endometrial carcinoma, we are practically talking about the C endometrium. Okay, then therefore cancer of the corpus uteri is commonly referred as a endometrial cancer. Initial local extension is usual to the myometrium, because locally from endometrium it will get inverted into the myometrium. Okay, then tumors arising from the stromal or muscular tissues of the myometrium are classified as uterine sarcomas, and they have a separate they are a separate group of malignancies. Okay, so from exam point of view, when we talk about the cancer of the uterus, actually, honestly speaking, cancer of the uterus does not mean the endometrial carcinoma, because uterus will have the endometrium as well as myometrium. But practically, we restrict our terminologies to the endometrial carcinoma when we talk about the cancer of the corpus uteri. Okay, so let's come to the anatomy and lymphatic drainage, and this is going to be very important. I have already mentioned, when you are writing the answer, you should write the basic anatomy of the organ which is involved. Okay, so the lymphatic system of the corpus uteri has three main lymphatic trunks. One, utero-ovarian or along the infundibulopelvic pathway. Second is a parametrial pathway, and third is a presacral pathway. Okay, so lymph nodes which are draining the uterus they are divided into internal iliac, that is hypogastric nodes. Then you have external iliac, common iliac, presacral nodes, and the para-aortic nodes. Okay, so internal iliac, external iliac, common iliac, presacral, and the para-aortic. And there are three pathways. One utero-ovarian pathway, that is infundibulopelvic. Second is a parametrial pathway, and the third is a presacral pathway. One of the important thing is about the infundibulopelvic pathway or the utero-ovarian pathway is that drains into the para-aortic. Okay, so the lymphatic spread towards the para-aortic nodes through the infundibulopelvic and utero-ovarian pathway, and this is very important because that will lead to the pattern of nodal mets, then surgical staging, para-aortic nodal assessment, and sentinel lymph node mapping. Okay, so this understanding is very important, that it will go to the para-aortic group of lymph nodes via infundibulopelvic lymphatic pathway. Okay, so in FIGO 2021 report that identifies common metastatic sites. So which are the common metastatic sites? One is the vagina, second is ovary, and third is the lung. Okay, so you may be asked in the vivas common metastatic sites for the carcinoma of endometrium. The answer should be vagina, ovaries, and the lungs. Okay, so actually, initially when the previously we used to teach this endometrial cancer, we used to say it is a surgical staging. Okay, but now the concept is changing. So historically, it was a stage surgically. Okay, sorry, clinically. Historically, the endometrial cancer was previously staged clinically, but the FIGO changed to surgical staging in 1988. Okay, but now This staging system was subsequently revised, including in 2009 FIGO revision, and then further update in 2021 and 2023. It's not only surgical staging, but it is a surgico-pathological staging. Not only that, the molecular classification has also been incorporated into this. So it is a surgico-pathological staging now. Okay, so histological verification of the tumor, including assessment of the grade and extent of the disease, is essential for the classification. Now let's talk about the histopathology of endometrial carcinoma. Okay. So, according to the classification which is discussed in this particular report, the common histology is, which we get, and the commonest one is the endometrioid carcinoma. That is the most common type. Endometrioid carcinoma is the most common type, and other rare types are the mucinous adenocarcinoma, that is mucin producing tumor. Then you have serous adenocarcinoma, which is aggressive and high grade type. Third is a clear cell adenocarcinoma, which is also regarded as a high grade. Third is a undifferentiated carcinoma, which is also aggressive tumor. Then neuroendocrine tumors are rare, and mixed carcinoma, where more than one carcinoma type is present. So each component will be significant when it is constituting around 10%. So commonest one is the endometrioid carcinoma. Others like mucinous adenocarcinoma, serous, clear cell, they are rare, but they are the aggressive or the high grade. Okay. So endometrial carcinoma itself, the commonest is the endometrial carcinoma, but that itself can have a variation or show variants such as squamous differentiation, secretory variant, villo-glandular variant, and the ciliated cell variant. Okay, so these are pathological or the histopathological variations of this endometrial carcinoma. So important classification concept. So basically previously when we used to classify this cancer, we used to say endometrioid and non-endometrioid carcinoma. Okay, so these were the terminologies which were used. So traditionally endometrial carcinoma was broadly divided into two. One is endometrioid carcinoma. Generally that is accounting for majority of the endometrial cancers, frequently presents at an early stage, and commonly it is a grade 1 or grade 2 type of malignancy. Often it is hormone dependent and relatively favorable clinical course. So endometrioid variety of carcinoma, relatively early age, favorable prognosis, grading is grade 1 or grade 2. It is a hormone dependent and favorable prognosis. While non-endometrioid carcinoma includes important aggressive histologies such as serous carcinoma, clear cell carcinoma, other high-risk histological type, and this distinction is important because it has got implications for prognosis and the management. Okay. Now next is a carcinosarcoma. Okay, so you have the carcinosarcoma. That means the malignant tissue has got two components. It shows the carcinoma component also, and it shows the sarcoma component also. That means it is a malignancy of epithelial component as well as it is the malignancy of the mesenchymal component. Then how you are going to stage this? Because initially also we mentioned that that is group. These sarcomas are grouped separately. Its staging is different. But when you have a carcinosarcoma, how you are going to stage? Okay, so understand this concept. Although carcinosarcoma contains both malignant epithelial component and malignant mesenchymal component, it is currently considered as metaplastic carcinoma. It is considered as a metaplastic carcinoma and is managed as an aggressive carcinoma. Okay, so the concept of metaplastic carcinoma, though this sarcoma has come as a metaplastic carcinoma, that is why carcinosarcoma is staged as a carcinoma. Okay, so this you will stage as a carcinoma. Okay. So coming to the grading. Now, what do you mean by grading? Grading is the resemblance of the tumor to the actual original tissue. How much resemblance with the original tissue and how much it is deviating from the original tissue as such. Okay, see, if more is the resemblance, that means it is a well differentiated. If it is deviation is more, that means it is a poorly differentiated. So grading is written as a GX when grade cannot be assessed. G1, that is well differentiated. G2, that is moderately differentiated. G3, that is poorly differentiated or undifferentiated. And you should know when you will call this as a G1, G2 and G3, that is grade 1, grade 2 and grade 3 concepts you should understand. So grading is based on the percentage of non-squamous or modular solid growth. Okay, so how much non-squamous or non-modular solid growth the tissue has, depending on that it is graded as a grade 1, grade 2 or grade 3. When the solid growth is less than 5%, it is graded as grade 1. If it is between 6 to 50%, it is graded as a grade 2, and if it is more than 50%, it is graded as a grade 3. Okay, so this you should understand how it is graded, because it has got a significance in prognosis and further management. Okay, however, in 2021 report, this grading is conveniently as a binary grading concept. Okay, they have given us a binary grading concept as a low grade and high grade. Okay, so low grade is a grade 1 and grade 2 are included into the low grade, while high grade 3 is considered as a high grade. Okay, so this binary grading concept has come in the FIGO 2021 report. Okay, however, this serous carcinoma, clear cell carcinoma, they are considered as a high grade. Okay, so they will come into the grade 3 or the high grade clear cell and serous carcinoma. For adenocarcinoma with squamous differentiation, grading is based on the nuclear grade of the glandular component. So when you have an adenocarcinoma which has got a squamous differentiation, then this squamous tissue is also have the deviation from the normal squamous, and this epithelial component will also have the deviation from the normal. So what exactly solid component of the epithelial you are going to count, or the solid component of the squamous you are going to count? So what does the report says? For adenocarcinoma which has got a squamous differentiation, grading is based on the nuclear grade of the glandular component. So we will take into account the glandular component. By this time you must have realized that lot of weightage is given to the histopathology. That is why I mentioned it is a surgico-pathological staging. Okay, so understanding the pathology is also equally important, and the molecular grouping also is equally important. We will proceed further. Okay. Now let us come to the FIGO staging of the carcinoma of the corpus uteri. So in 2009 staging, it is presented in the cancer report 2021, and then further there is a recent update in FIGO 2023. Okay, that is the that has the major update in FIGO 2009. Okay, so there is a major update in 2023 in the classification. Now I have grouped older classification also and newer classification also. So by any chance, if you have read the older classification, you can compare with the newer classification. Okay, so in the stage 1, basically stage 1 where the malignancy is confined to the uterine corpus. Okay, in the older classification. As per the newer classification, the malignancy confined to the uterine corpus and the ovary. Okay, and here they have given the notation as a C. Okay, here 2023 FIGO staging of the cancer of the endometrium, and they have given some notation as a and B here. Okay, small notations. These small notations are going to be very, very important, because there are certain concepts which are there, and at the end of this classification they have given in a small footnote. So we will go into the details of those footnotes also. So previously it was stage 1, that is the tumor which was confined to the corpus uteri. Now the stage 1 is cancer which is confined to the uterine corpus as well as ovary. Okay, so previously the stage 1 was divided into 1A and 1B. In 1A there was no myometrial invasion, or the myometrial invasion was less than 50%, and more than or equal to 50% is a 1B. So this was very easy to remember. Either no myometrial invasion or less than 50% is 1A, and more than 50% is a 1B. However, now in 2023 they have divided each stage 1, stage 2, stage 3, stage 4 into A, B and C, and there is further substaging into that. Okay, now let us talk about stage 1. Stage 1 we have seen. What is the difference? Here the cancer is confined to the uterine corpus as well as ovary, but this one is further divided into 1A, 1B and 1C. Similarly, stage 2 is also divided into stage 2A, 2B and 2C. Okay, now just for the understanding point of view, remember when we are talking either in 1C or 2C, okay, 1C or 2C will be representing the aggressive type of tumors. They are pertaining to the aggressive type of tumors. Okay. Now let us go into details of one by one substage. Okay. Now 1A, where the disease is limited to the endometrium or non-aggressive histological type, that is low grade endometrioid with invasion of less than half of the myometrium with no or focal lymphovascular space involvement, and it has got a good prognosis disease. Okay, so basically here 1 is further divided into 1A, B and C, and 1A they have divided into 1A1, 1A2 and 1A3. Okay, now let us go to the older classification. Older classification is less than 50% and more than 50%. Okay, now here this here 1A1 is a non-aggressive histological type limited to the endometrial polyp or confined to the endometrium. A2 is non-aggressive histological types involving less than half of the myometrium with no or focal LVSI. Okay, so here less than 50% has become 1A2 now. Okay, so what is 1A1? Where the malignancy is confined to the endometrial polyp or to the endometrium, and this is a non-aggressive histological type. Okay, so up till now we have seen in the histology you have aggressive and non-aggressive. So A1 and A2, stage 1A as such is concerned with the non-aggressive only. Okay, so 1A1 is a non-aggressive histological type limited to the endometrial polyp or confined purely to the endometrium. Okay, so no myometrial invasion, they have divided into A1 and A2. Okay, so no myometrial invasion has become a 1A1, that is the confined to the either endometrial polyp or confined to the endometrium, and it is a non-aggressive histological type. 1A2 is a non-aggressive histological type involving less than half of the myometrium with no or focal LVSI. So this component has become the 1A2. Okay, and what is 1A3? This 1A3 you have to understand very well. Okay, so concentrate on 1A3. 1A3 is a low-grade endometrial carcinoma limited to the uterus and ovary, and they have given the notation as C. So this 1A3 concept you have to remember, it is a low-grade endometrioid carcinoma which is limited to the uterus and ovary. And now if you see the older classification or even in the newer classification, ovary involvement, that means adnexal involvement. When the malignancy is involving the adnexa, it goes to the stage 3. But here it is included into stage 1A3, provided it is a low grade endometrioid variety of carcinoma limited to the only one ovary where the capsule is intact, and it is a low-grade endometrioid carcinoma. So there are certain specific criteria. If these criteria are fulfilled, then it is classified as a 1A3. The capsule should be intact, it should be unilateral involvement, and it should be the low-grade endometrioid carcinoma only, not any other variety. Then it is classified as a 1A3. Okay, so previously whatever was a 1A and 1B, that is divided into 1A1 and 1A2, and A3 has come new. 1A3 has come new because of the inclusion of the ovary, but they have given certain criteria, and we will further go into the details of 1A3 later on. And remember, this 1A3, if you read it opposite, it becomes 3A1. Okay, so ovarian involvement ideally comes stage 3A1, that we will see further. But if the criteria are satisfied, it will come under 1A3. Okay, now coming to the stage 1B, it is a non-aggressive histological types with invasion of half or more of the myometrium and with no or focal LVSI. That means 1B has remained 1B here. Okay, 1B has become remained 1B. 1A has become 1A2. Before that was included only no involvement of the myometrium and endometrial polyp as 1A1, and ovarian involvement with inclusion of all satisfaction of the all criteria has become 1A3. I have already mentioned, when you are talking about 1C or 2C, always talk about the aggressive type. Okay, now if you 1C is your aggressive histological type, limited to the polyp or confined to the endometrium. Okay, so this endometrial polyp or endometrium, which was 1A1, but if it is a aggressive, it becomes 1C, not 1A1. Okay, so when you are talking about the histological aggressive histology, which is limited to the polyp or endometrium, it becomes 1C, and if it is a non-aggressive, it becomes 1A1. Okay, I hope stage 1 is clear to you now, and we have compared with the older classification also. Now come to the stage 2. Now when you talk about the stage 2, you should know what are the hallmark of the stage 2. Stage 2 hallmark is the involvement of the cervical stroma. Okay, remember, cervical stroma, not the glandular involvement, should not be considered as a stage 2. It is the cervical stromal involvement. Second, presence of LVSI, and third, aggressive with myometrial involvement. Okay, so these are the three important things. So when we talk about stage 2 of endometrial carcinoma, what we are going to see, if the cervical stroma is involved or not, if the LVSI is there, substantial LVSI is there or not, and third is a, if it is an aggressive histology, as I mentioned, 2C is going to be aggressive histology with any thickness of the myometrium. Okay, so let us talk about stage 2 now. Stage 2 is the invasion of the cervical stroma without extrauterine extension or with substantial LVSI, or aggressive histological types with myometrial invasion. Okay, so that is the stage 2. So stage 2 is also further divided into 2A, 2B, and 2C. So 2A is the invasion of the cervical stroma of non-aggressive histological types. Okay, so 1A, 2A, 2B, we are going to talk about non-aggressive. Okay, 2C, we are going to talk about aggressive. Okay, here non-aggressive, here aggressive. Okay, so 2A is a cervical stromal involvement, 2B is the substantial LVSI of non-aggressive histological type, and 2C is the aggressive histological type with any myometrial involvement. So here if you see 1A2, where non-aggressive, less than half of the myometrium or focal LVSI was 1A2. But if it becomes aggressive and it is less than 50%, then also it will become a 2C, because it is aggressive with any myometrial involvement. I hope you are getting this particular difference. That is why it is a surgical as well as histological or pathological, surgico-pathological staging I mentioned. Okay, so previously stage 2 tumor invades the cervical stroma but does not extend beyond the uterus. Here, one of the important point you should remember, endocervical glandular involvement alone does not make it is a tumor stage 2. You have to have a cervical stromal involvement and not the glandular involvement. Okay, so if only glandular involvement is there, then it is considered stage 1 under this system. Okay, now let us go to the stage 3. Okay, now stage 3 is also divided into 3A, 3B, and 3C. Okay, and 3A is again divided into A1 and A2. 3B is again divided into B1 and B2. 3C is again divided into C1 and C2. And C1 is again divided into C1I and C1I, that is micromets II. Okay, C2 is also divided into further 2 subsets. Okay, so this you have to remember. Basically, now stage 3, where there is a local and regional spread. Okay, now how you are going to remember stage 3? Okay, you have to remember A, B, and C. Okay, so remember, serosa and adnexa is A, serosa and adnexa is A, then vagina and parametrium, VPP, vagina, parametrium, and pelvic peritoneum is B. Okay, and C is always lymph node. Lymph node involvement is a C. So that is how you will remember SA, VPP, and lymph nodes. You remember this way. SA is a serosal involvement and adnexal involvement. Okay. B is VPP, vaginal involvement, parametrial involvement, and pelvic peritoneal involvement. C is a lymph node involvement, which may be pelvic and or para-aortic. So if it is a pelvic, then it is C1. If it is a para-aortic lymph node, it is a 3C2. Okay, so that is how you will remember stage 3 of the endometrial carcinoma. So 3A is a serosal involvement and or adnexal involvement. 3B is a vaginal and or parametrial involvement, oblique pelvic peritoneal involvement. 3C is a pelvic and or para-aortic lymph node mets, and 3C is again divided 3C1 where the pelvic lymph node mets is there, 3C2 where the para-aortic lymph node mets with or without pelvic nodes. Okay, so this is the classification which is given in the FIGO report 2023. So stage 3 is the local and regional spread of the tumor of any histological subtype. Any histological subtype where there is a local and or regional spread. Now this is 3A, 3B and 3C. 3A is the invasion of the uterine serosa, adnexa or both by direct extension or metastasis. Okay, so 3A is a spread to the ovary or fallopian tube except when meeting stage 1A3 criteria. When we were discussing at 1A3, at that time we mentioned that if it is an adnexal spread, it comes under stage 3A. Except these 1A3 criteria, if they are satisfied, it becomes 1A3. If the criteria are not satisfied, it becomes 3A. Okay, it is very easy to remember. 1A3 is exactly opposite of 3A. Okay, 3A1. Okay, so 3A1 is the involvement of the ovary or the fallopian tube or the adnexal involvement. A2 is involvement of the uterine subserosa or spread through the uterine serosa. Okay, so adnexa and serosa is in 3A. Adnexa is A1, serosa is A2. Okay, now coming to the stage 3B. Okay, now in stage 3B, VPP, vagina, parametrium and pelvic peritoneum. Out of which, if it is a vagina and parametrium involvement, it is 3B1. If it is a pelvic peritoneal involvement, it is 3B2. Okay, so what is 3B? 3B is a metastasis or direct spread to the vagina and or to the parametrium or to the pelvic peritoneum. And if metastasis or direct spread to the vagina and or parametrium, it is 3B1. And if it is to the pelvic peritoneum, it is 3B2. Okay, so it is VPP, vagina, parametrium is in 3B1, pelvic peritoneum is in 3B2. Okay, 3C is the lymph node. Lymph node, two groups of lymph nodes. You have pelvic group of lymph nodes and you have para-aortic group of lymph nodes. Pelvic group of lymph nodes is 3C1 and para-aortic group of lymph nodes is a 3C2. Now, in each, if it is a micromets, now what do you mean by micromets? If the involvement is less than 2 millimeter, then we call it as a micromets. If it is more than 2 millimeter, we call it as a macromets. Okay, so accordingly, further you label this as 3C, and this is small Roman I, and this is 3C1, 2. That is macromets. Okay, so similarly, 3C2 is metastatic to the para-aortic lymph nodes up to the renal vessels with or without metastasis to the pelvic group of nodes. So up to the renal pelvis is 3C2. Okay, that is also, if it is a micromets, you will remember mention 3C21 and 3C22 macromets. Okay, so that is how it will be written. Okay, stage 4 is a bladder or bowel mucosal involvement and distance metastasis. Stage 4, this is older one. Okay, in older you had only two. Okay, 4A and 4B, that is invasion of the bladder and or bowel mucosa, and 4B was a distant mets including intra-abdominal mets and or inguinal lymph nodes. Okay, now as per the newer classification, stage 4 is a spread to the bladder mucosa and or intestinal mucosa and or distant mets. Okay, so this is also further divided into A, B and C. Okay, A is the invasion of the bladder and the intestine and or intestinal mucosa. B is abdominal peritoneal mets beyond the pelvis. Remember here also pelvic peritoneum was involved in 3B2. Okay, here also 4B, but the abdominal peritoneum is involved. Okay, so 4B is the abdominal peritoneal mets beyond the pelvis, and 4C is a distant mets including the metastasis to any extra or intra-abdominal lymph nodes above the renal vessels, lungs, liver, brain or both. Okay, so here you have the lymph node involvement above the renal vessels, while here the lymph node involvement was below the level of the renal vessels. Okay, up to the renal vessels, that is 3C2. Okay, so that is what is the difference between the all four stages. Each stage is divided into A, B, C, and how to remember. Okay, now let's see, there are many footnotes for this newer classification. We are going to go into the details of each. Okay, so basically, when we are staging this endometrial carcinoma, certain things which we should know, that the endometrial cancer is primarily staged surgically and pathologically. Okay, so for every stage, we have to record histological type, grade, and LVSI. Okay, then molecular classification is now encouraged wherever feasible, and you should classify into one of the four, that is POLEmut, MMRd, that is a mismatch repair deficient, then NSMP, that is no specific molecular profile, and P53 abnormality, that is abnormal P53. Okay, so for your exam, you should remember certain things, that this FIGO 2023 update about the staging includes anatomical staging plus histology plus grading plus LVSI plus molecular classification wherever it is available. Okay, so molecular classification is particularly important for prognosis and treatment and risk group stratification. Okay, second concept is the surgery and lymph node staging. Okay, so standard surgery in early stage of the endometrial carcinoma. What is the standard surgery? It is the total hysterectomy plus bilateral salpingo-oophorectomy. That is the surgery which is required in early endometrial carcinoma, and preferably it should be done by the minimal invasive method. That is, if laparoscopy is available, you should preferably go for laparoscopic total abdominal hysterectomy with bilateral salpingo-oophorectomy wherever applicable. Then what about the omentectomy? So routinely, if you are dealing with the endometrioid variety of adenocarcinoma, then not routinely require for endometrial carcinoma, but you will consider the infracolic omentectomy, particularly you are dealing with high-grade cancer such as serous carcinoma, undifferentiated carcinoma, and carcinosarcoma. Why? Because these histologies have a higher risk of microscopic omental metastasis. Okay, so in early disease, if it is a high grade, then you will do total abdominal hysterectomy plus bilateral salpingo-oophorectomy plus infracolic omentectomy. Okay, now about the lymph nodes. Okay, so what does the report says about the lymph nodes? So it is the sentinel lymph node biopsy, especially in the intermediate, high, or the high risk disease. Sentinel lymph node biopsy is an adequate alternative to systemic lymphadenectomy for lymph node staging. So regarding the lymph node staging, instead of going for systematic lymphadenectomy, you can go for sentinel lymph node biopsy as an alternative. And definitely, if the sentinel lymph node is positive, you will perform the full lymphadenectomy. Okay, so this is the thing. And if you are dealing with a low or intermediate risk disease, then as a sentinel lymph node biopsy can be considered or may also be considered to detect the occult metastasis and confirm that the disease is truly confined to the uterus. So that means that if the SLN is negative, that means truly you are dealing with the earlier stage where the carcinoma is confined to the uterus itself. Okay, so in low or low intermediate, you consider the sentinel lymph node biopsy, while in a high grade, in intermediate or high risk disease, SLN biopsy or sentinel lymph node biopsy is an alternative for your systematic lymphadenectomy. Okay, then this is the same thing which the European Society of Gynae Oncologists, the European Society of Oncoradiotherapists, and European Society of Pathologists, they follow the same. That is, the sentinel lymph node assessment is essentially in all patients with endometrial carcinoma. But one thing we have to remember, SLN biopsy should be accompanied by the ultrastaging. So concept of ultrastaging is very, very important. That means you are taking the first draining lymph node and you are assessing. Now, when you do the histopathology, you will just mention the lymph node is positive or negative. If you see the tumor in the lymph node, you will mention the node is positive. If the tumor is absent, you will mention node is negative. But ultrastaging, what the ultrastaging means, you have to study it very carefully, and because ultrastaging improves the detection of micromets and low volume nodal disease. So it is not only the presence of the tumor cells, tumor in the lymph node you have to detect. You have to see the burden in the lymph node also. That is the ultrastaging. Okay, so do not interpret sentinel lymph node is used only in high risk endometrial cancer. The newer concept is sentinel lymph node can be used across the risk groups with particularly important role in intermediate, high and high risk disease. Okay, so if you remember, if you can understand this, when we are talking about endometrial carcinoma, first thing, do we need a nodal assessment? Go for sentinel lymph node mapping. You identify the sentinel lymph node. Once you identify the sentinel lymph node, go for ultra staging. This ultra staging of the lymph node will classify either it is a lymph node negative, or you have got a tumor cells, okay, small tumor cells which are present. Then you may get a micro metastasis, or you have a macro metastasis. Okay, so you will classify the lymph node into these. Okay, either lymph node is negative, or individual tumor cells are detected, or it is a micro metastasis, or it is a macro metastasis. Okay, and integrate this with the histology, grade, molecular type, and uterine factors, and then you come to the final staging and adjuvant treatment. So this ultra staging of the lymph node is also very, very important. Stage 1-3 concept, 1A3 concept we have already discussed, but we'll just revise it once again. Stage 1A3. Okay, this is one of the new FIGO 2023 concept that is highly can be asked. Okay, so it is the low grade endometrial carcinoma involving both endometrium and ovary. So it has to be low grade endometrioid carcinoma. It has to be low grade, not the high grade. Low grade means grade 1 or grade 2. Okay, low grade endometrial carcinoma, which is involving endometrium as well as ovary. This does not automatically mean the stage 3A1. Okay, so ovarian involvement ideally should go to 3A1, but if it is a low grade endometrioid carcinoma involving endometrium and ovary, it is classified as a 1A3, provided following criteria are fulfilled. A special category called stage 1A3 exists for selected cases. To qualify as a stage 1A3, all four criteria should be satisfied. That means myometrial invasion should be absent or superficial, that it should be less than 50%. LVSI, either there is no LVSI or no substantial or extensive LVSI. Third, there should not be any other metastasis. And fourth, ovarian disease should be unilateral, confined to the ovary, and there should be no capsule invasion or rupture. So if all these four criteria are satisfied, then we can label this as a 1A3 and not 3A1. Okay, so this concept you have to understand in the newer classification. Okay, and the tumor should be low grade endometrial carcinoma. This is very important. All these if it are present, but if this histopathology low grade endometrioid is not there, then you cannot use this 1A3. Okay, so why this is important? Because these patients have a good prognosis, and if all criteria are fulfilled, no adjuvant treatment is recommended. Okay, so that is why the concept of 1A3 is important. Okay, now low grade endometrial carcinoma plus endometrium plus ovary does not automatically make it stage 3A1. Okay, so if it is low grade endometrioid variety of carcinoma, which is restricted to the endometrium and ovary itself, it is not a stage 3A1. You need to ask further question, does it fulfill all stage 1A3 criteria? That is the all four criteria we have discussed. If it is fulfilling, then we will label this as a 1A3. If it is not fulfilling, then we will label this as a 3A1. Okay, so this concept you have to understand. That is why there was a small notation C. Okay, so everything you have to understand about the notations. Second, the report also talks about the extensive or substantial LVSI. Okay, so FIGO uses the WHO 2021 classification definition itself. Same definition is there for LVSI. Extensive and substantial LVSI is the one where 5 or more vessels are involved. So 5 or more vessels are involved, then we call it as a substantial LVSI, lymphovascular space invasion. Okay, so this is clinically important because if there is a substantial LVSI, it is associated with increased risk of nodal metastasis, extrauterine spread, recurrence, and worse prognosis. That is why LVSI is very, very important. And if you have got a extensive or substantial LVSI, which is 5 or more vessels, then the prognosis will be poor. So next important concept is a histological grade. I have already mentioned about the grading. It is grade 1, grade 2, grade 3. Okay. So by convention, histologies that are high grade by definition, if you do not have this endometrioid, if you have other varieties, non-endometrioid varieties, by definition itself becomes a high grade. Okay. So you don't need to calculate the grade of the disease for non-endometrioid, that is serous carcinoma, clear cell carcinoma, mesonephric-like carcinoma, gastrointestinal type mucinous carcinoma, undifferentiated carcinoma, carcinosarcoma. These are by definition high grade carcinomas. Okay, so you don't have to calculate the grade for this. By definition, they are high grade. If you have an endometrioid variety of carcinoma, then you will calculate the grade and will grade it as a grade 1, grade 2, or grade 3. Okay, now how this grading is there, it will depend upon how much is the resemblance to the original tissue. Okay, so grade 1 where there is a solid component less than 5%, grade 2 if there is a solid component between 6 to 50%, and grade 3 if it is a more than 50%. Okay, now another important concept is a nuclear atypia. Okay, now you are grading the tumor, but at the same time you have to look at the nuclei. If there is a nuclear atypia, that itself can upgrade the tumor. For example, if there is a marked nuclear atypia which is disproportionate to the architectural grade, okay, so when you grade it, it looks as either grade 1 or grade 2. But if you specifically look at the nuclei and this nuclear atypia is there, then grade 1 tumor may become grade 2. Grade 2 tumor may become grade 3. That is why nuclear atypia can upgrade the tumor. Okay. So if an apparently low grade endometrioid tumor shows unusual or prominent nuclear atypia, then you have to go for evaluation of P53 or consider whether the tumor could actually represent the serous carcinoma. So this is what is the interpretation. Maybe ask in the viva. Suppose if you have got a nuclear atypia, what you will think of? We will think of the P53 evaluation, or we will think of the whether we are dealing with the serous carcinoma. Most of the time pathologists will think about this, but as a clinician, we have to evaluate for P53. Okay. Then next is a squamous differentiation. Okay, sometimes your endometrioid carcinoma can have a squamous differentiation. Then you will have the question, how I am going to grade this tumor as per the squamous or as per the epithelial component. So you have to take into account the adenocarcinoma and not the squamous component. Okay, so if an endometrioid adenocarcinoma has got a squamous differentiation, grading is according to the glandular component and not the squamous component. So do not grade the tumor based on how aggressive the squamous component appears. Okay. Now let's talk about the non-aggressive versus aggressive histology. Okay, so which is the non-aggressive histology? Essentially, it is a low-grade endometrial carcinoma. Either grade 1 or grade 2 is considered as a non-aggressive histology, while aggressive histology will include grade 3 endometrioid carcinoma, serous, clear cell, undifferentiated, mixed carcinoma, mesonephric-like carcinoma, gastrointestinal type mucous carcinoma, and carcinosarcoma. These are the aggressive, and that is why if you see in the staging, I have mentioned when you are talking about stage 1, A and B, we are dealing with a non-aggressive one. 1C and 2C, we are dealing with the aggressive histologies. Okay. Then do not equate endometrioid is a low risk. Endometrioid does not mean low risk. Okay, so because grade 3 of endometrioid carcinoma is classified as an aggressive histology. So the first here it is written is a grade 3 of endometrioid carcinoma is an aggressive histology. Okay, so just you get an endometrioid carcinoma, does it mean that it is a non-aggressive? No, grade 1 and grade 2 is classified as a non-aggressive, while grade 3 endometrioid is classified as a aggressive histology. Okay, now next is a grade 3 endometrioid carcinoma. the molecular classification is very, very important here. This is another important concept which the student should know. Grade 3 endometrial carcinoma is heterogeneous. Different molecular subgroups can have different prognosis, biology, recurrent risk, and treatment implications. So when you have grade 3 carcinoma, you have to know the molecular profiling. Okay. So molecular profiling, there are 4 groups as we have discussed. Okay. Molecular profiling is particularly recommended for grade 3 endometrial carcinoma. If molecular classification is not available for practical purposes, grade 3 endometrioid carcinoma is grouped with aggressive histology. If you do not have the molecular classification, then group this as an aggressive histology, okay, to avoid the under treatment. Okay. So grade 3 endometrial carcinoma plus molecular classification. Okay. So this you have to understand, because it can modify the prognosis and the risk classification. Now, this molecular classification, what is? There are 4 groups. So FIGO 2023 incorporates the 4 molecular groups, that is POLEmut, where there is a pole mutation, then MMRd, mismatch repair deficient, NSMP, that is no specific molecular profile, and P53ABN, that is abnormal P53. And this can influence the prognostic stratification, risk grouping, adjuvant treatment decision, and systemic treatment decisions. Okay, so that is why we need to know molecular classification also. Okay, now coming to the lymph node metastasis, that is the another important concept. So when we talk about macromets, macromet means more than 2 millimeter tumor you get in the lymph node, we say it is a macromets. Micromets means 0.2 to 2 millimeter, up to 2 millimeter, then we say it is a micromets, or more than 200 tumor cells. Okay, and isolated tumor cells, that is ITCs, if you have got a less than 0.2 millimeter or less than 200 cells, if they are present in the lymph node, then we classify it as a ITC, that is the isolated or individual tumor cells, but their number is less than 200. Okay, less than or equal to 200 is ITC, and micromets is between 0.2 to 2, and less than or equal to 0.2 is ITC. Okay, so if you count the tumor cells and if they are less than 200, it comes as a ITC. Okay, this is called as ultrastaging. So when you do the histopathology of the lymph nodes, you have to see whether it is a macromets, whether it is micromets, and or whether it is a ITC. Okay, now what is the significance of this? Okay, now your nodal finding may be macro, maybe micro, or maybe ITC. Okay, but when you are going to mention in the FIGO staging or the TNM classification, how you are going to mention? If it is a macromets, definitely it is a metastatic node. Definitely macromets more than 2 millimeter, that means node is positive. Okay, if it is a micromets, then you have to mention it is a micron. Okay, so you will mention PN1 in bracket MI, that is a micromets. But if it is ITC, okay, ITC, you will mention PN0, okay, PN0, and in bracket you will write I plus. That means it is the isolated tumor cells are there. Okay, so here it is N1, but here it is N0. That means we are, whatever we are recording, reporting, that we are documenting it into the staging also. Whatever you see histologically, we are doing ultra staging. This ultra staging also you need to utilize in your staging. Okay, so micrometastasis is metastatic disease, but ITC is not a conventional nodal metastasis because it is not reported as N1, it is reported as N0, and in bracket you are documenting I plus. That means you are finding the isolated tumor cells which are less than 200. Okay, or the tumor burden is less than 0.2 millimeter in the lymph nodes. Okay, so the prognostic significance of the ITCs is still unknown, okay, or uncertain. So ITC should be documented but regarded as a PN0. Okay, and in bracket you will mention I plus. Ultra staging we have discussed. SLN assessment should undergo pathological ultra staging. Why? Because it can detect the micrometastasis and very small volume disease, that is isolated tumor cells also it can detect. So this is particularly relevant because a patient who appears node negative on routine examination may have a low volume disease detectable only by ultrastaging. Okay, so otherwise node negative on routine examination, but if you do the ultrastaging, that means you have to take out the multiple section and you have to study many sections and come to a conclusion whether it is negative, whether it is ITC, or whether it is a micro or macro. Okay, so now just see the summary of whatever we have seen up till now. So staging is a surgical plus pathological. Always record the histology, grade, and LVSI. There are four molecular groups which you should know: POLEmut, MMRd, NSMP, and P53ABN. Okay, so standard surgery is a total abdominal hysterectomy plus bilateral salpingo-oophorectomy. However, you will go ahead with the infracolic omentectomy, especially when you are dealing with the serous and differentiated or carcinosarcoma. Then coming to the lymph node lymphadenectomy. Here, sentinel lymph node dissection or sentinel lymph node biopsy is an alternative to systematic lymphadenectomy for nodal staging. SLN in low risk can be considered to detect the occult nodal disease. SLN pathology, when you take out the sentinel lymph node, you have to go for ultra staging. Okay, this is very important. Now, stage 1A3 concept we have discussed in detail. Selected low grade endometrioid carcinoma involving endometrium plus ovary. Okay, so what are the 1A3 criteria? Less than 50% myometrial involvement, no substantial LVSI, no other mets, and unilateral ovary. It is confined to the only one ovary and capsule is intact. Okay, what do you mean by substantial LVSI? When lymphatic vessel involvement is 5 or more, we call it as a substantial LVSI. High grade definition, by definition, which tumors are high grade? When you are dealing with serous, clear cell, mesonephric, GI mucinous, or undifferentiated or carcinosarcoma, these are a high grade definition. Then we have grade 1, grade 2, grade 3. Up to 5% solid, it is grade 1. 6 to 50% is solid, is a grade 2. More than 50% solid component is a grade 3. If you have got a nuclear RTPI, your grading will be upgraded by 1. Okay, and you may have to think about the P53 evaluation or consider whether we are dealing with the serous pathology. Okay, if it is a squamous differentiation, then you will grade as per the glandular component. Okay, so which are the non-aggressive type and which are the aggressive type? Non-aggressive is a grade 1 and grade 2 of endometrioid carcinoma, while aggressive is a grade 3 of endometrioid carcinoma along with rest of the other high grade histology which we have discussed. Then coming to the grade 3 endometrial carcinoma is particularly heterogeneous and you will go for molecular profiling. That is very important. And if you do not know the molecular profiling of the grade 3 endometrial carcinoma, then you will consider this or you will group it as an aggressive histology for all practical risk classification. Macromets is more than 2 millimeter. Micromets is a 0.2 to 2 millimeter and or more than 200 tumor cells, and it will be written as a P and 1 in bracket MI. While if you get isolated tumor cells, more than 0.2 millimeter involvement or less than 200 or equal to 200 cells, then you will label this as a P and 0 in bracket I plus. Okay, so there are few important things which you will remember. FIGO 2023 is not just anatomical staging, it includes the molecular classification along with the histology also. Always record histology, grade, and LVSI. Sentinel lymph node is can be considered across all risk groups. It is not restricted only for the high risk disease. Okay, ultrastaging is important along with sentinel lymph node dissection. Okay, so stage 1A3 is not same as stage 3A1. Okay, then 1A3 requires all four criteria. Substantial LVSI is more than or equal to 5 vessels. Grading we have seen. Then grade 3 endometrioid carcinoma is heterogeneous. Molecular profiling is very important. And micromets, that is P and 1 MI, whereas ITC is P and 0 in bracket I plus. So that is how it is denoted. And this is what is the classification which we have gone into the detail. It has got 4 stages: stage 1, stage 2, stage 3, and stage 4. And this each stage is divided into A, B, and C. Okay, stage 1 is disease confined to the uterus. It is 1 is divided into 1A1, 1A2, and 1A3. Okay, 1A is divided into 1A1, 1A2, and 1A3, and 1 is divided into A, B, and C. Okay, so 1C and 2C will always have the aggressive histology. Okay, so 1A1 is a non-aggressive histological type confined to the endometrium. 1A2 is a non-aggressive histological, less than 50% myometrial invasion with no focal LVSI. 1A3 is a low-grade endometrial carcinoma involving uterus and ovary, fulfilling all. So 1A3 concept is very clear. 1A2 is your less than 50% involvement, and 1A1 is new, where you are there is no myometrial involvement or polyp is there. Okay, then 1B is your non-aggressive with more than 50% in myometrial involvement and no focal LVSI, and 1C is your aggressive histological type confined to the endometrium without myometrial involvement. So it is here either polyp or confined to the endometrium without myometrial invasion is 1C. 2C hallmark is cervical stromal involvement, substantial LVSI, and aggressive histological type with myometrial involvement. So 2A is non-aggressive with cervical stroma. 2B is non-aggressive with substantial LVSI. 2C is aggressive with any myometrial invasion. Is a 2C. Okay. In stage 3, what we have seen, SA, VPP, then lymph node involvement. SA is a serosal and adnexal involvement. That is adnexa first, then serosa. So 3A1 is adnexal involvement. A2 is uterine serosal involvement. B1 is vaginal parametrial involvement. B2 is a pelvic peritoneal involvement. C1, C is lymph node involvement. That is C1 and C2. That is pelvic is C1 and para-aortic is a C2. And this further has got a micro and macro in each. Okay, then 4 is divided into A, B, C. That is the bladder or bowel mucosal involvement and or distant mates and abdominal peritoneal mates. Okay, so B here is a abdominal peritoneal. So 4A is a invasion of the bladder and bowel mucosa. 4B is abdominal peritoneal mates, and 4C is a distant mates. Okay, including extra or intra abdominal lymph nodes above the renal pelvis, lungs, liver, brain, etc. Okay, so just for the remember, A is 3A adnexal and serosal involvement. B is below the uterus, vagina, parametrium, and pelvic peritoneum. C is nodal involvement. Okay, that is also C1 and C2, pelvic and para-aortic. Okay, so from important things related to the staging. Sometimes, suppose if you get a peritoneal cytology, positive peritoneal cytology, then positive cytology should be reported separately. It does not alter the FIGO staging. Your peritoneal cytology is positive, but the FIGO staging will not be altered. FIGO staging will remain same, but you have to document it. Okay, so it does not alter the FIGO stage in the staging system. Okay, important pathological prognostic factors. Apart from the stage, important pathological factors will include histopathological type, histological grade, depth of myometrial invasion, lymphovascular space invasion, and molecular classification. This is important viva concept which can be asked when you are talking on the endometrial carcinoma. The lymphovascular space invasion, LVSI, is a positive tumor which has got a worse prognosis, particularly when LVSI is extensive or substantial. Then how you mention, either it can be focal LVSI or substantial or extensive LVSI. What do you mean by focal LVSI? Focal LVSI is a single focus around the tumor shows the LVSI. While in substantial or extensive, you have got a multifocal or diffuse LVSI or tumor cells in more than 5 lymphovascular spaces. Then you say that this is a substantial or extensive LVSI. Okay. So in stage 1 disease, LVSI status may be highly important for prognosis because greater prognostic relevance than simply distinguishing 1A from 1B in some situation. Okay, so LVSI status in early stages is also going to be very, very important. So finally, we will conclude and in summary, corpus uteri, it is restricted to the upper 2/3. When we talk about the uterus, it is the upper 2/3 of the uterus. Then most corpus cancers arise from the endometrium. There are 3 main lymphatic trunks which we have seen. One goes along the uteroverinous, second is a parametrial, third is a presacral. Common metastatic sites are vagina, ovaries, and lung. Carcinosarcoma is treated and staged as aggressive carcinoma. Endometrial grading, grade 1 is less than 5%. Grade 2 is 6 to 50%. Grade 3 is more than 50% in solid growth. Endocervical glandular involvement alone is not stage 2. Okay, you have to have a stromal involvement to say it is a stage 2. Okay, then stage 3C1 is a pelvic nodes, stage 3C2 is a para-aortic lymph nodes, and positive parental cytology does not change the stage under the system used in the FIGO 2021 report. Major prognostic factors include the histology, grading, biometric invasion, LVSI, and the molecular classification. So that finishes the today's topic of staging of the carcinoma of endometrium. Thank you.